Let's start with the hip fractures. Now we're moving on to the first, the surgical anatomy. As I told you, there is a joint called as hip joint, which is a ball and socket joint formed between the three bones of the pelvis, that is the ilium, ischium and pubis. They form a combined acetabular cartilage, and which is actually articulates with the head of the femur. If you see it over here, this is where the hip joint is being formed. This is the femur, which has its proximal part. This is the head of the femur, greater trochanter, lesser trochanter, and proximal intertrochanteric part, as well as subtroch part of the femur. It articulates with the basic socket of the acetabulum, which is actually formed by the three bones union, that is the ilium, the ischium, and the pubis. As you know, this is actually where the axial skeleton meets the perpendicular skeleton as well, where the sacroiliac joint is present, and spine actually articulates with the ilium and with the sacroiliac joint. And why it is important? Because all the axial load which is actually coming in is transmitted towards the body by at this sacroiliac joint. This is the acetabulum formed by the three bones, which is the head of the femur forms the ball, and the acetabulum forms the socket, and there is an articulation of ball and socket joint with proximal part of the femur, including the greater trochanter, lesser trochanter, as well as intertrochanteric part of the femur. Although sacrum does not directly articulates, but actually forms the part of this whole pelvis and acetabulum. And then we have coccyx, although as I told you, the pubis, ischium and ilium form the acetabulum. Now coming to the mechanism, how one can have actually a hip fracture. There are multiple mechanisms. Usually when in young adults, this is associated with very high energy trauma. For example, RTA, car accidents, or maybe fall from a bike at a very high speed. But with old age, although these intertrochanteric and neck of femur fractures are actually more common in the old age, and in old age there's usually history of a trivial trauma, like old lady or an old man would come and will give a history that he or she actually slipped from stairs. There was only one or two steps of stairs, or she just had a bump, and then she just fell off from a, let's see, standing height, and then this resulted after that he was unable to move. And this is a classical history. Usually in old ages, actually trivial trauma, very minor amount of degree of trauma, but this usually results in either the neck of femur fracture or intertrochanteric fracture. And why it occurs? Because in old age the bones have become osteoporotic, and usually results in a damage or fracture even despite a very small energy of trauma. This is a classical history. An old lady will present with a history of she stubbed her toe, and then she just slipped out, and when she fell on the side, and resulting in this sort of a fracture. Now coming to the classification. There is one way of classifying these fractures is in form of anatomical classification. For example, if you see the femur over here, this is the articular surface. The area just below that is called as the subcapital area. And then there is this area in the middle of the neck. This whole part is actually neck, which is further subdivided into three parts. This is termed as the transcervical area, and area which is adjacent to the intertrochanteric region of the femur, that becomes the basicervical area. Now what is important is one way of classifying the neck fracture is as according to region. Usually they're not, because there is a Garden and Powell classification which are specifically designed for this region. And why it's not classified anatomically is because we need to assess whether the avian of head is going to occur or not, because that is what is the most important thing. You need to save the hip joint, otherwise you may need a very large surgery like total hip replacement to replace this femoral head for normal hip articulation. Then this is the intertrochanteric area, and then there is a subtroch area. Subtroch area is at least considered as 5 cm below the level of the lesser troch. This is the lesser troch. 5 cm below the level of lesser troch is termed as subtroch area. Any fracture here would be considered as subtrochanteric fracture. Any fracture in the neck would be considered as a neck of femur fracture, and all that fractures which occur in between these two areas is termed as intertrochanteric fracture. There are multiple classifications for intertrochanteric fractures. There is Boyd and Griffin classification, there is Kyle classification, there is Evans classification. We'll be briefly discussing in the subsequent slides actually. As I told you, this becomes the intertrochanteric area between the greater and the lesser troch. Then there is a peritrochanteric and subtrochanteric area as well. Now coming to the Garden classification. Garden and Powell classification is basically for the neck of femur fractures. It has 4 subtypes. Stage 1 is considered as Garden 1 when we call it. What is Garden 1? It is actually the undisplaced fracture with a partial fracture as well, with valgus impacted. If you see it over here, this is probably would show if there's a thin line going like this and it ends here. This is not a complete fracture, it's an incomplete fracture which is undisplaced as well, and there's a valgus impaction of it slightly as well. This is classically type 1 or stage 1 Garden classification. Stage 2, if you see the diagram here, it's a complete fracture but it still is undisplaced. So type 1 and type 2 are undisplaced, but type 1 is incomplete while type 2 is complete. And you can appreciate in the x-ray this whole line is going like this, but still mainly the neck is undisplaced here. What about type 3? Type 3, you have a complete fracture which is partially displaced. When it is partially displaced, and how we know on AP view, it's very not easy to know with exactly what is the difference between 3 and 4. And sometimes all you know is there is a complete fracture which is either partially displaced or completely displaced as well. If you see the trabecular line in this diagram, these are the trabecular lines going in this, and then it becomes this. In the 1, 2, and even in the 4, all the trabecular lines would be parallel to each other. But in type 3, the trabecular lines become perpendicular to each other. This becomes type 3 injury. So when you are viewing an AP X-ray and you are not sure whether it's partially displaced or it's completely displaced, best way is to look at on the AP view of the hip joint, look at the trabecular lines. If they're parallel and it's a complete fracture and it looks displaced, then it is a type 4 injury, which means mostly completely displaced. If it's partially displaced, then these lines will be perpendicular to each other. For example, if you see this, now if you see this x-ray, you can appreciate a complete fracture. Looks like a complete displacement. This is one part and this is the other part. There is a definitely clear-cut displacement. But if you see clearly the trabecular lines look parallel to each other, which means that this is type 4. If the trabecular lines would have been perpendicular and in this kind of a picture, then this would have become the type 3 injury. That is how the Garden classification is actually done. Garden 1 is incomplete fracture and non-displaced. Garden 2 is complete fracture but not displaced. Garden 3 is complete fracture partially displaced, and Garden 4 is complete fracture completely displaced. Now there are other classifications as well. Before moving on to the intertrochanteric fractures, one is called as Powell classification. But why its Garden is important and Powell is also important, because you need to have a lateral x-ray at times for the Powell classification. Lateral x-ray is not always possible because the patient is having a fracture, is usually in quite a bit of a pain. Normally that is why we mostly rely on the Garden classification, but Powell classification sometimes is very useful because we know that how much chances of AVN is there. According to Powell, there are 3 subtypes, type 1, 2 and 3. In type 1, the angle of displacement is less than 30 degree. Type 2 is 30 to 50 degree, and in type 3 it's more than 50 to 70 degree of displacement. Higher the displacement, higher the Powell, higher the Garden. If it's type 3 or 4 Garden and type 2 or 3 Powell, this means that actually the AVN of the head, there is increased chances of having an avascular necrosis of the femoral head. So this is what it actually depicts. But the main mechanism of all this classification is not to actually classify them just for the sake of classifying it, but actually to understand whether how much chances of avascular necrosis of the head is actually there or not. If there are high chances, we need to explain to the patient that despite the adequate fixation, adequate reduction, there is always chance 6 months, 1 year down the line, you may be complaining of the same pain, the same hip area, and when we get CT or MRI, and we end up having an avascular necrosis of the femoral head despite adequate fixation and reduction, because the initial injury was quite of a high degree value if it was Garden 4 and Powell 3. Now coming to the intertrochanteric fractures. As you know, once the neck is after the region which after neck which comes is actually the intertroch area. It is also called as pertrochanteric fractures as well. There are also plethora of classifications for that. One is the Kyle one, the other is the Boyden-Griffin, the third type is the Evans as well. But again, what's important over here is the different classifications have different way of classifying it. But what's more important is that we need to understand that this fracture is stable or unstable. That is what primarily is determined by the classification. And why I'm going towards, because we need to understand the end point this time. In Garden and Powell and the classification of the neck, the end point was whether the AVN would occur or not. In intertrochanteric fractures, the end point is whether this fracture is inherently stable, inherently unstable. There is a posterior medial cortex. This in our human body, what happens is the posterior medial cortex of the proximal femur is highly thickened and it forms called as calcar. If the calcar is intact, the fracture, even if it is intertrochanteric fracture, would be inherently stable. But if calcar is actually not intact, that is the fracture the posterior medial cortex of the femur intertrochanteric area, this would mean that usually this means inherently unstable and you need a different implant for that. First, I will be going through the Kyle classification and I will briefly describe the Boyden-Griffin as well and why we go for Kyle rather than Boyden-Griffin, or why we can use both interchangeably as well. Now, Kyle classification actually depends upon the fracture line and pattern and comminution actually. Type 1 is undisplaced and uncomminuted. It's classical intertrochanteric fracture. The fracture line starts right from the greater troch, comes all the way back to the lesser troch. This is actually Kyle type 1. Similarly, in even Boyden-Griffin type 1, this is the same pattern. This is what it is in Boyden-Griffin type 1 as well. Now type 2 is a minimally comminuted. Lesser trochanteric fracture is in varus. That is, there is actually, this is the pattern usually is. This becomes a kind of a 3-part fracture in which the lesser troch is actually avulsed. Now, this is where the difference actually starts. Lesser troch, if it is damaged, that would inherently make it slightly unstable as compared to type 1. Type 3 is there is a displaced greater troch as well as combination as well as the varus of the lesser troch as well. If you see, this is more unstable than this and this is more unstable than type 1. Now, this is where the difference between the Kyle and Boyden-Griffin comes in. In Boyden-Griffin, these both types are actually type 2. But Boyden-Griffin is slightly different because it does not take into account the combination. But if the combination is present, it becomes inherently unstable. That is why usually now there's still a debate whether to use a Boyden-Griffin classification or to go for a Kyle classification. And it's some use Kyle, some use Boyden-Griffin. It's slightly different, but it's more or less the same thing. What matters is that you have to decide whether the end point is stable, there is a stable fracture or unstable fracture. And that will determine the choice of implant you have to use. Now, type 4 is severely comminuted subtrochanteric extension, also called as reverse oblique. And this is actually Boyden-Griffin type 3. In reverse oblique pattern means it starts from the lesser troch and goes all the way downwards toward the shaft. This is the Kyle classification, and when you have Boyden-Griffin classification, Boyden-Griffin classification is also of type 4s. Type 1 is undisplaced intertrochanteric fracture. Type 2 is you have basically different patterns of combinations from greater troch to lesser troch. It could be in this shape, it could be in this shape as well, but these all become type 2. Type 3 is wording of a reverse oblique pattern, and in type 4 actually it's increases in severity because there is two types of fracture. There is a reverse obliquity of the intertrochanteric area, and femoral shaft is actually also broken in a different plane as well. So there is two plane fracture in type 4 Berding Griffin. So what is important to understand it is that as the number increases, whether it's the Kyle 1 or 2 or it's Berding Griffin 1 or 2, as the number increases, the severity of combination and instability increases. So you have to understand that for example, if you want to fix this fracture or this type of fracture, you cannot have the same type of implants, because you may be having a good implant to fix this, but you cannot have the same implant which is being using for type 1 to fix this type of type 4 injury. And that is where that role of stability, inherent stability of fracture comes in. And we have actually advanced classification to exactly address that. But usually nothing is concrete in a way that you cannot be 100% sure that you have to go with this sort of a classification. There may be maybe 4 or 5 years down the line, maybe another classification to address the same issue. But what matters is you need to understand that whether calcar is intact or not. If it's intact, it's inherently stable fracture. If it's not, it's inherently unstable fracture. Now coming to the reverse oblique intertrochanteric fractures. As I told you, the fracture line could be comminuted or it could be a single fracture line. It starts with the lesser troch and goes all the way downwards and outwards toward the shaft or subtroch region. This is classically, you see, if this is it happened, the fracture line is going like this, and there is also fracture line which is involving the going up towards the greater troch area as well. Now coming to the subtroch hip fractures. As you know, the subtroch region is actually 5 cm below the lesser troch level. If the lesser troch ends here, this area is actually termed as subtroch fractures. Now the hip fractures clinical features. As I told you, patient maybe sometimes very difficult to initiate that where know whether you have a neck of femur fracture or intertroch fracture just by having clinical history. But you definitely would know that probably something is wrong with the hip joint. And the most important features include, first and foremost is actually history of fall. Especially in old age, there will be a history of trivial trauma, like patient will complain that he or she just stubbed her foot and then fell on this side, or then just fell out from a standing height and resulted in this sort of injury. Definitely there will be pain, whether on the right or left side, depending on which side is involved. There will be inability to walk. A patient would complain that as soon as he or she just fell, after that she's unable to bear weight on this side and she's not been able to walk. And sometimes there will be some degree of displacement which may be visible or which may not be visible, especially regarding the leg. But you will eventually have to get the x-rays to exactly evaluate the fracture pattern. Leg may be externally rotated and shortened, or it may be internally rotated and adducted. For example, if it's a subtroch fracture, there may be leg lies in a neutral or external rotation and looks short, or there may be a thigh may be swollen as well. Now, swelling of thigh means shaft of femur fracture. This could be subtroch femur fracture as well, or it could be even the swelling of thigh may be present due to hematoma as well. So sometimes clinically you cannot exactly judge that whether it's neck of femur, it's intertroch, or it's subtroch fracture. For that you need examination, and after that you need exactly the x-rays to understand what type of injury it is. Coming to the diagnosis. For example, if you see this x-ray, do you see any fracture line? This is probably the Garden type 1. There is a slight suspicion of injury, incomplete valgus impactor fracture, which may or may not be visible. If this is a kind of a situation and patient has a clear-cut history, we may have to go for a 15 to 20 degree internal rotated view of the hip joint to exactly analyze the neck, which becomes more visible in that kind of a situation. and first and foremost are always the x-rays. Then we may have to go for MRI later on as well. Why MRI is done? For example, if patient comes to you with a history, let's say he or she had a fall around 6 months back, later on they did not really bother to consult a doctor, and after a few months, she's unable to walk, she's emaciated, there's a lot of problems with it, and on x-ray there's a neck of femur fracture. Then you have to understand that whether the head is actually still vascular or it has become avascular, because that will alter the treatment you want to give it to her. And then we may have to go for some form of MRI or even sometimes CT as well. Why CT is required? Because sometimes when there is a highly comminuted fracture, we need to get a CD with the 3D reconstructions to view exactly the degree of comminution and plus the geometry of the fracture properly. Now, once we have when we know it's most likely the subtroch fracture, the way to make a diagnosis is always the first and foremost is the x-rays, and we may require CT later on, but usually x-rays are more than enough, especially the x-rays of the hip joint. Then there is a classification as well. Again, there are a lot of classification for subtroch as well. There is a Russell-Taylor, there is a Schiemer classification, but more or less they point out to the same thing. Russell-Taylor is a classification which based on the extension or geometry of the fracture. The fracture in the subtroch, is it extending into the piriformis fossa or not? This becomes type 1. If it's extending into the piriformis fossa, which is present over here, and this is type 2, in which the fracture is in the subtroch but it does not extend into the piriformis fossa, or it could be an undisplaced fracture as well. Now, what is the treatment for these fractures? Whether it's a neck of femur fracture, it's intertrochanteric fractures, or in subtroch fractures. Again, what is more important is what is the age of the patient. For example, if a child comes to you of let's say 14 or 15-year-old and had a neck of femur injury, then you need to go and save the head first. You need to do some internal fixation, in which could be in form of screws as well, so that the head of the femur is actually saved. If a patient comes to you, let's say he or she is 65, 70-year-old female who comes to you with a history of neck of femur, now there will be although increased chances of avascular necrosis, plus you may have to, instead of saving the head, you may have to go for fixation, internal fixation in form of either total hip replacements or hemiarthroplasty. So there are different options available for the neck and intertrochanteric fractures. For intertrochanteric fractures, the options may include a simple dynamic hip screw or dynamic compression screw, which has now become obsolete because it was used around 20-30 years ago, but now it's mostly obsolete. Either it's dynamic hip screw or other modalities have actually come into play, like proximal femoral locking plate and proximal femoral nail in form of a gamma nail. Now, there are plethora of classifications, and there is a plethora of implants which are available to fix a fracture. What determines is how to choose a implant which would be more suitable for the type of a fixation. If it's neck of femur, what depends upon is whether what's the age of the patient, and do we need to save the head of the patient or not. If we want to save the head, you'll have to go for some form of a cannulated screws and internal fixation with cannulated screws. But if we do not want to save the head, patients of an age, let's say 65, 70 or 60 above, then probably we can either go for total hip replacement or hemiarthroplasty in form of a bipolar hemiarthroplasty for the neck of femur. Similarly, if you see, this is actually a diagram which actually shows what is the normal alignment is normally 160 to 180 degrees. If you see on AP view, normally it should be between 160 to 180 degree, and then this is how we fix the neck of femur fractures. And on lateral view, when we are viewing it, it's usually between 160 to 180 as well. And ideally, it should be 165 and 180 on the lateral side, or 165 on the AP view. But that is the ideal. But the range usually means anything between 160 to 180 is acceptable. But if this is not acceptable, if you see this is, there is definitely displacement which is visible on the lateral view. But form of internal and fixation, if you see this, there is actually a different type of fractures which may or may not be visible at times. This is a lateral view, and how we assess it after reducing it, we need to look at whether what are that. If you look at closely, these are the trabeculae going like this, and on this it's going like this. So you need to measure it over this on AP and the lateral view, and then assess whether you have accurately reduced it or not. And then once you have accurately reduced it and you know that the fixation would be adequate, then you apply either, if depending upon it's an adult, you have to, the neck is wide enough, and you can go for 3 cannulated screws in form of this, in the shape of a triangle, as you can see it over here. Or if it's a child, or let's see it's a very teenage boy or a girl, then probably the neck is not wide enough, then you can also go for 2 screws which may be parallel as well, like this. Now if this is an AP view of 3 cannulated screws being passed, and this is the lateral view, if you see it's in form of a this kind of a triangle. There is 1 screw on the top and the 2 and this is actually these reverse triangle, the 2 on the top and 1 is going in the posterior medial cortex, so that the posterior medial calcar is actually made stronger over here by this 1 reverse triangle screw. And if you see it on this, these are the 2 on the top, and this is that reverse triangular screw which is going actually into the posterior medial cortex. Now coming to the prosthetic replacement. If, for example, the same patient had a neck of a femur, but his or her age was, let's say, above 60, then this is what you, let's say a 65-year-old female or a male comes to you with this sort of history. Then you have to go for either the prosthetic replacement in form of total hip replacement or in form of hemiarthroplasty. This is actually a bipolar hemiarthroplasty which has been done. Why I know because bipolar, because this there was no actually done this acetabulum is actually still native. A bipolar hemiarthroplasty was done in which the femoral stem has actually been put in place. Or you can also go for total hip replacement. Total hip replacement could mean metal on metal total hip replacement, in which the acetabulum socket can be replaced by a metal socket, or you can go for this sort of a thing in which there is a cemented metal on poly type of a total hip replacement, in which the polyethylene liner has been placed with the cement intact, and you have actually a metallic femoral component which is in place as well. But that depends on the age of the patient. And if the patient head is salvageable, we have to go for cannulated screws. If head is not salvageable, we have to go for either the hemiarthroplasty or the total hip arthroplasty. Now coming to the treatment of the intertrochanteric fractures. The point which I was discussing is actually comes right here now. If the calcar was not intact, which means the fracture pattern is inherently unstable, then we have to go for some form of a stable fixation. If the calcar was intact, which means the posterior medial cortex is intact, we can go for some form of less stable fixation as well. So if it's Boyd and Griffin type 1 or 2, we can go for some form of dynamic hip screw or DHS, this screw which is very much visible on this diagram, or even the DCS as well. But if it's Boyd and Griffin type 3 or 4, in which there is a reverse oblique pattern and there is either 2-part fracture of the femoral shaft as well, then DHS and DCS would not be sufficient because the fracture pattern is inherently unstable. Then we will have to go for either the proximal femoral nail in form of a gamma nail or proximal femoral locking plate to fix the combination of the fracture. If you see this is the reverse oblique fracture in which this has been shown, and actually different patterns have been used to actually fix it. Now this is a Boyd and Griffin type 2 fracture. You can appreciate a greater troch is going in like this. Reverse oblique pattern would mean going from this towards lower down. And if you see in this pattern, there is definitely fracture line. This posterior medial cortex is not intact and it's unstable. For this fracture, dynamic hip screw has been adequate and the fracture reduction is quite excellent. But for this sort of a fracture, if you go with dynamic hip screw, you can appreciate it despite having a lot of screws in and all this, still the fracture is actually collapsing and it's not showing a very good results. So for reverse oblique and two-part fractures, you may have to go for some form of other treatment, that is in form of proximal femoral nail or gamma nail, which can be appreciated. This is another reverse oblique pattern or subtroch femur fracture. If you appreciate it over here, in case of it, gamma nail was passed and the fracture reduction is quite excellent as compared to the dynamic hip screw. Now coming to the subtroch fractures. Again, there is a Sheen-Shimmer classification, Russell-Taylor classification. What matters over here is whether there is extension into the piriformis or not. If there is extension into the piriformis, we may have to go for, if for example this was the X-ray, this is a fracture which is actually starting right here and going all the way up to the piriformis, you can go for a dynamic compression screw or even the recon nail as well. But if it's kind of a subtroch fracture not going into the extending into the piriformis, we can go for proximal femoral nail in form of a gamma nail as well, or even the proximal femoral locking plate can also be utilized depending upon the combination of the fracture fragments in the subtroch region. Now coming to the complications which generally associated with hip fractures. They may include comorbidities. What usually happens is these are old age patients like 70s and 80s, and they have a lot of other issues like heart issue. There is a problems like there are issues like they may have or they may be on other antiplatelet and blood thinning medications. They may be also taking multiple other medications for some like hypertension, diabetes and all that. They may have a very low ejection fraction as well. So these are all associated with the really hip fractures due to old age. Other is deep vein thrombosis. If these fractures are left untreated, eventually the patient will not be able to bear weight for a very long time. Like it takes at least 2 to 3 months to actually get back to normal. If patient would be lying for 2 to 3 months, this would usually result in a lot of DVT, and this DVT can be dangerous because it can lead to pulmonary embolism and thromboembolic phenomena. As I told you, that once the clots start to form in the peripheral arteries and veins, they can be very dangerous because usually these patients are taking some form of blood thinning medication as well. And once the DVT has formed, these medication actually dislodge this sort of a clot and can lead to pulmonary embolism. Other option is due to continuous being on the bed. This may result in atelectasis, and atelectasis can eventually predispose to infection and causing severe form of pneumonia as well. And above all, because they are bed bound, this can result in bed sores right from the occiput till the ankle. There could be bed sores over the occiput if they're lying flat. That could be at the sacral region. This could be at the calcaneal region as well, because all these areas are actually in direct contact with the bed and the hard surfaces. The foremost and most dreaded complications, if for example of the fractures in young adults or in children or in teenage population, is actually the osteonecrosis of the femoral head. Why we need to worry about it? Because if for example, let's say an 18 or 20-year-old young girl had some form of RTA resulting in a neck of a femur fracture, and as you need to save the head, you went in with the internal fixation with cannulated screws. For example, this is what was done, but 6 months or 1 year down the line, you get an X-ray, the patient is complaining of hip pain is still not settling down, and he is not completely back to normal before what it was before the accident. And you get an X-ray and this is what you see. Can you appreciate over here in this X-ray that the head has actually deformed well? There is no concentric shape of the head is also lost. Physis is gone, and there is definitely subchondral sclerosis with some lytic areas which is very much visible, with loosening of the cannulated screws as well. So then what to do with this sort of a thing? In the point, what is important is you cannot go for, let's say, at age of 20 for total hip replacement, because eventually patient is going to live a very young active adult life, and eventually it's going to wear off quite quickly. So you cannot go for second or third surgery at the age of a 30 or a 40. So that is why in young population we need to be very meticulous for reduction. We need to properly reduce it. We need to be, and that is where the reduction of that roll comes in. On AB view it has to be 160 degree, and on lateral view it has to be between 160 to 180 degree. Proper reduction would prevent avascular necrosis of the head and would actually prolong, will not result in a more prolonged misery for the patients. Coming to the complication, if osteonecrosis does occur, then we may have to, this is just actually taken out head from a patient which has actually had an osteonecrosis. If you can appreciate, this is the cartilaginous area which is actually eroded, and you can appreciate in the subcapital, and this transcervical area starts right here. This is the subcapital area. All this area is actually necrosed, only some part being left out, and this is actually extending into the transcervical area. The same patient may have an X-ray like this. There may be fissures, and you can see the lysis here, increased sclerosis over some areas, and fissures and lysis and breakage of the head in multiple segments. On AP view, what you need to look at is whether the first and foremost the shape of the head is intact or not. Then there is a FICAD classification and how to diagnose it, what is the stage of AVN, and if it's very early stage you may need a bone scan and MRI to diagnose the AVN of the head. On X-ray it may appear very much completely normal as well, or it could appear like this. If you see there is sclerotic limb on the acetabulum, head has lost its shape, so definitely the avascular necrosis has started. Now coming to the complication of intertrochanteric fractures. If you see this area, now this was actually the gamma nail was done, but this actually still the fracture has collapsed. This collapse would result in more of a problem in hip pain. Other option could be the cutout. Can you appreciate the screw as actually the cut out and moved out of the head of the femur if it is not being properly reduced and placed in place? Other most dreaded one are actually this kind of a scenario in which the nail actually breaks in the middle and you may have to redo everything as well. Now what's important over here is vascular supply is coming all the way upward going toward the head of femur. So in this kind of scenario you need to be worried about it. Fine, maybe they need to look at the head as well, whether it has gone into some form of AVN or not. And then there is another kind of a complication you can appreciate. Again, this was actually dynamic compression screw which has the angle of 95-degree blade plate, but it is actually cut out of the head and going into the posterior medial cortex because the fracture has collapsed. Now coming to the isolated fractures of the trochanters. As you know, the proximal femur has a greater troch and a lesser troch. Iliopsoas is attached on the greater troch, while the tensor fasciolata and other gluteal muscles are actually attached in the greater troch area, and they have a role in the mechanism of biomechanics of the hip. This could be an isolated injury to greater troch, could be in form of avulsion fracture, an isolated avulsion fracture of the lesser troch as well. What happens is that if there is such, we need to understand if it's a very small fracture which may heal over time, but if it's displaced, then we may have to fix it in form of a single screw or like this. For example, if this is what happens, is a displaced in lesser fracture, because then iliopsoas will not be able to act on the hip joint. You need to fix it back with a single screw so that it stays in its place. Proximal femoral fractures in children. Neck of femur is highly susceptible to avascular necrosis, and there is actually a different classification as compared to it. In children, we use more of that anatomical classification than using that Garden and Paul classification. That is, the classification name was given by Delbert. That is why it is called as the Delbert classification. Type 1 is transepiphyseal injury, in which the epiphyseal is actually avulsed. Now type 1 is further divided into type 1A and B. 1A is transepiphyseal, which is undisplaced, and transepiphyseal which is displaced. Why I'm discussing this transepiphyseal? Because this is the most notorious one, and if it gets displaced, if you can appreciate it over here, whole epiphysis is moved out and metaphysis and diaphysis remains in place. This may be having a chances of 98 to 100% of avascular necrosis of the hip joint. And for example, if a child, let's say 10, 11 or 12 years of age, has this problem, then it is highly likely that eventually patient will have some form of AVN and will require some form of surgery later. Now type 2 is actually the transcervical. It's in this zone area, although this is also associated with as high as, some books say 28%, some say 25%, some articles say as high as 40%. So this is maybe associated with 30 to 40% of the avascular necrosis of the head. Type 3 is actually less likely, but it is associated with 15 to 20%, some books say 18%, and this is around cervicotrochanteric involving the basicervical area as well as the trochanter area. Type 4 is classical intertrochanteric fracture, which is highly rare, associated with avascular necrosis of the head, and the treatment varies right from this. For type 1, 2, you may have to go for cannulated screws, which may be, as the neck may not be large enough, you have to go for 2 cannulated screws and internal fixation. And for type 3 and type 4, you can go for screws, as well as you can also go for pediatric DHS or dynamic hip screw. Now coming to some of the imaging for the fixation, if you see this, how I know it's more like the child, because some physis is open, but this is either basicervical or cervicotrochanteric fracture, and usually can be managed in some form of pediatric screw fixation or even the cannulated screws as well. Now this is the transcervical, or this is called as cervical area involving the neck of the femur of the children, and it has to be fixed with the cannulated screws. This is transepiphyseal, which may require later on the bone scan to know whether the patient has got AVN or not. We have discussed in this lecture about the fractures around the hip. They may include fractures like fractured neck of femur, which could be, there could be Garden. There is a Garden and Powell classification based on the fracture displacement and whether there's a complete or incomplete fracture. Then we have discussed briefly the intertrochanteric fracture and the mechanism to different implants which can be used to fix that. The important point over here is that in case of a neck of femur fractures, if we want to save the head, we have to go for cannulated fixation, cannulated screw fixation. But if we want the age of the patient such that we do not need to save the head, then probably we can go for either total hip replacement or hemiarthroplasty. In case of intertrochanteric fractures, the implants usually utilized depend whether the calcar or the posterior medial cortex is intact or not. If it's intact, we can go for DCS or DHS, but if it's not intact, we have to go for dynamic proximal femoral nail or the proximal femoral locking plate. Usually the gamma nail or proximal femoral locking plate is a recon nail is usually suffice for the subtrochanteric fracture as well. We have discussed briefly in this lecture the Delbert classification of children. What is important is that we need to understand and counsel the patient regarding the avascular necrosis of the head, because that is the most dreaded complication, and this is what our effort should be, to save the femoral head from having avascular necrosis. Thank you very much. Keep watching sqadia.com.